patients. Nurses have always evidenced concerns about the adoption of safe practice in order to avoid negative healthcare outcomes related to practice and to increase patients' quality of life. The healthcare motto is primum non nocere, first do not harm. In this sense, health professionals have a duty to provide safe healthcare. However, due to the rapid technological evolution in the health, the complexity of professional relationships, economistic measures to do not allow for adequate patient-nurse ratios, the habits and beliefs of health professionals, as well as the difficulty in increasing and implementing scientific evidence, many healthcare interventions are not adequately provided, either due to lack of knowledge or time. Thus, it is important to recognize the factors that contribute to patient safety or unsafety, and to involve and raise awareness among nurses for the implementation of scientific evidence. Nurse managers also play a key role both in supporting continuous improvement measures and in creating and monitoring indicators related to patient safety. In the last years, health literacy among patients has been increasing, therefore causing an increase in the demands for better interventions and quality of care provided, which is why patients often take legal actions when they feel wrong. All of the above highlights patient safety as one of the biggest challenges in the world. In fact, in the World Health Assembly in 2019, adopted a resolution on global action in patient safety and mandated the development of a global action plan for patient safety, and in 2021 reinforced to the need for a world in which no one is harmed in healthcare and all patients receive safe and respectful care at all times, in all places and all circumstances. Today, we will discuss the role of nurses in patient safety, and we are honored to have as speaker Sofia Macedo, who will present us with overview on healthcare safety global concerns, Anabela Coelho, who will present us with patient safety culture in Portugal and worldwide, Teresa Bisson, who will present to us understanding the impact of work-related incivility in nursing on patient safety, and Mahawi Wang, who will present us reflect on the journey to safe staffing regulation in Saudi Arabia. We kindly ask you keep your microphones on mute and write your questions and reflections in the chat. This webinar is organized by members of the Phi-Xi chapter of Sigma and as the institutional support of Coimbra Nursing School and the Health Science Research Unit Nursing. The Phi-Xi chapter thanks you for your presence, and we wish you all a good webinar.
Hello everyone, good afternoon. We will start with Sofia Macedo. I will do a brief curricular presentation. If Sofia, if you want to add an extra curricular note, please do. Sofia Macedo is a registered nurse with a master's in evidence-based healthcare, fundamentals of Magnet certified as well. And she is currently working as clinical leads director at the Ministry of Health. And please, Sofia, the floor is yours. Thank you very much for your presence.
Thank you, Rafael. Thank you, Philip, Paulo, for the technical support and for the chapter for inviting me and my following colleagues to be part of this webinar to discuss a very important subject. I will now share my screen. I hope, please, Paulo, Philip, or Rafael, please let me know if something doesn't look
We
right.
will.
For sure, just give me 1 second. Yeah. Let me see. Okay, you can see my screen now, right?
Not really.
Can you see it or no? Not yet.
No, not yet.
Okay.
It's not sharing at all so far.
Okay, so let me go back. I'm trying to, share. Okay.
Now we see it.
Now it. Okay, you can see
great.
it?
Yeah, that's great,
Okay,
Sophia. Thank you.
perfect. Okay, so I promise I'll be mindful of the time, because I usually tend to go a bit over, but I'll take care of that. So my next talk will be a 20-minute conversation on overview of healthcare safety global concerns. So I'm not going to focus on a specific topic. My colleagues will do that after me, and I'd like us to think through my presentation on healthcare as an industry. Okay, not just we tend to separate healthcare from the other industries, and at the end of the day, more and more we look into the management and the leadership of healthcare as in the same lens of other industries, and perhaps this will be good to do so, considering the record of the safety patterns of the other industries. And I have this slide that it was developed 2 years ago for a specific event that shows us the safety levels of other industries such as nuclear, gas and oil, and aviation throughout the years, specifically from 1964 until 2008. As you can see, years ago, these industries, they were not as safe as they are today. All these industries, they had moments in their lifetime where something so serious happened that they've changed the way they looked into safety. Whereas in healthcare, I believe we all agree that we've had several moments where we could have taken that opportunity, and so far for several reasons, it hasn't happened yet. So let's look at two healthcare safety numbers. And if you've noticed so far, I'm trying to deviate from the term patient safety into healthcare safety, especially because throughout the pandemic and now we have more awareness that patient safety is not just about the safety of patients, that there is a lot that needs to be done to ensure patient safety that relates to the healthcare environment as an overall. So this is why you will see me saying healthcare safety instead of patient safety most of the time. So let's look at the numbers. Okay, so healthcare safety. Before the start of the pandemic, 1 in 10 patients were harmed while receiving hospital care. And those numbers, they are a bit scary, but we need to make sure that we understand them so we know what to tackle. Unsafe care results in over 3 million deaths each year worldwide. 4 in 100 people die from unsafe care in the developing world. The risk of healthcare associated infections in low and middle income countries is 20 times higher than in high income countries. However, it's not to say that we don't have unsafe care, of course. Around almost $400 billion US, it's the forecasted cost to the global economy by 2022 due to patient safety issues or healthcare safety issues. Unsafe care disproportionately impacts LMIC countries, where 134 million adverse events occur in hospitals every year, contributing to 2.6 million deaths, according to WHO. And the social cost, we're not just talking about the direct cost, like when we harm somebody, the physical or the physiological effects of it, but the social cost of patient harm goes beyond $2 trillion US a year. And the OECD tells us that eliminating harm could boost global economy growth by over 0.7% a year. So as you can imagine, this is a lot of the money that we could use instead of treating unsafe care to actually prevent it. So this is very important to know. Now, we tend to talk about numbers all the time, but we can't forget that behind each number, there is a face. There are families that have been affected. There is a person that has been affected by care that was provided by us unsafely. And I would like just to show you some of those faces. So this slide means a lot to me, and some of my colleagues have seen it before, which is healthcare safety in faces. Some of these people, you recognize them. There are particular stories behind them. Some people, we don't recognize them. However, this slide means that unsafe care, like if we want to compare it to COVID, does not choose whether you're rich or poor, whether you're, your ethnic background, who you are, if you're famous or not famous, like COVID did, right? So it affects everybody, and therefore, for every number we mention, there is a face behind it that we need to be aware of. Now, the magnitude of healthcare, between brackets, patient harm, it's worth looking at the burden that it causes when you put it in perspective of other conditions. I like to treat patient or healthcare safety or unsafe healthcare as a disease, let's say. And therefore, this slide, it's quite, I wouldn't say old, even though it's from 2015, it does show a lot. Because it puts into perspective where adverse events sit in relation to other conditions that we sometimes think are more serious to look at. So, for example, the number of lives lost plus the years of lives lost due to disability, consequence of patient harm, was in total of 64 million years. This is more than the lives lost to malaria or tuberculosis. And the annual global disease burden of unsafe care, it's quite similar to road traffic injuries and HIV, like we can see here in this graph. Now, what happens when someone is harmed? So again, this is another slide that was developed for the G20 event that we had in Saudi in 2019. And the focus of the slide is basically to show us healthcare professionals and policymakers and people, governance and ministers, that when someone is harmed, each country loses twice. And the reason behind is because the harmed person will stop being considered a profit center, as you can see here on the upper square, as he or she won't be able to contribute anymore to the economic growth of the country, because the person will stop working, and it as a consequence of the disability associated to the harm caused to him or her. And in addition to that, it will become also a cost center, as this person will require prolonged treatment and care, because it will become dependent on the government support, we'll have to give them allowances and might not even be able to join the workforce again. So it becomes, I don't want, I don't want anyone to get offended by the word I'm going to use, but it somehow becomes a burden to the healthcare system and to the overall country economy as well. So how many people actually die of unsafe care as per the United Nations? So United Nations a while ago told us that 5 avoidable deaths per minute occur every year, and which requires a global action for patient safety. So patient safety becomes a global priority that goes beyond healthcare. It's actually a challenge for the economy of the country, and therefore requires the attention of other stakeholders and heads of state. If we take this number, and we did this exercise during COVID time, if we take this number, the 5 avoidable deaths per minute annually, we wanted to compare to the magnitude of this to the magnitude of death caused by COVID last year. And we came up with this, very simple, but yet quite a meaningful slide, showing us very quickly that patient harm was actually killing more people than COVID-19 at that time, actually a year ago, in May 2021. So again, it's not to take the seriousness of the pandemic away from it, but it's to show us that while the pandemic happened and did kill millions of people around the world, we did have people dying of unsafe healthcare that got even worse because of the pandemic as well. And therefore, we should have put some more awareness and more focus on that, which did happen. I think the healthcare safety community is just afraid that, while the COVID pandemic fades away, that the concerns and the awareness also does, but hopefully that won't happen. So what are the contributing factors for unsafe care? So overall, the most pronounced contributing factors can be organizational systems, poor readiness, overwhelming workload, time pressure to make decisions among the healthcare professionals, individual human factors, cases, uncertainty and complexity, and lack of training and evidence-based health protocols. Now, who are the victims of preventable harm? The victims it's never just the patient, it's the other patients and the families, and they get affected from the physical, physiological, and financial standpoint. The healthcare workers, which this has been raised more and more, especially the pandemic kind of brought that fact up, where healthcare workers, they will be affected also physical, psychologically, and also legally, like our colleague Philip mentioned in the beginning. Patients do tend to raise legal actions against healthcare workers, which has an impact in our careers. And also the facilities. The facilities are now being called the third victim. We have the first victim, which is a patient and families. The second victim, which is a term that it was pinpointed by Dr. Albert Hu, considering the healthcare work as the second victim of unsafe care. And now we have the third victim, which is a facility where they lose trust, reputation, and affects them financially and also legally. Now, if those of us that that do remember the report that came out 20 years ago, we should wonder, why do errors still occur? There has been an immense amount of evidence put forward on how to decrease the gap, and therefore we wonder, what's lacking on implementing safe care. So the lack of the following components are really the reason why the implementation gap remains, and we can divide them in culture compared to other industries that have transformed safety, like aviation and the other industries I've mentioned. Information asymmetry, where patients know less than we do, and we need to empower patients and families in this regard. Lack of resilience compared to other industries, the lack of advocacy as well, where we should definitely put the same level of awareness in patient safety as we do for other causes, and the lack of collective wisdom and learning to tackle this issue globally. Now, what would be the top pre-pandemic? And this is, I don't want to sound, as if the pandemic has stopped or it's over. It's not. But if we want to put it in those terms, before the pandemic, let's say that the patient safety concerns that we would see more that we would talk more about will be medication errors, healthcare infections, surgical errors, diagnostic, false communication, patient identification errors, sepsis, VTEs, and so forth. Now, if we try to do the exercise of what are the top 10 patient safety concerns post-pandemic, or right now in 2022, if we don't want to say post-pandemic, they change slightly, and they change because the world has changed. And if a lot of the things have changed because of COVID, the unsafe care profile has also changed. And this is quite interesting to read about. And the top 10 concerns that we can be or start preparing ourselves to are staffing shortages that we had before pandemic anyway, COVID-19 effects on healthcare workers' mental health, bias and racism in addressing patient safety. This is quite interesting. Non-ventilator healthcare associated pneumonia. We tend to focus on ventilated associated pneumonia, but we should also right now focus on non-ventilated ones. Vaccine coverage gaps and errors. Products subject to emergency use authorization. As we could see through the pandemic, a lot of medication were authorized to use that required less evidence on safety and efficacy. So we should also be aware of that. telemetry monitoring. The more and more we utilize technology to monitor healthcare and to monitor our patients, there are safety concerns associated to that we need to be aware of. International supply chain disruptions, human factors in operationalizing telehealth. Telehealth, again, because of COVID-19, has become more trendy. We have to be mindful that there are human factors associated to it that we need to tackle and we need to be concerned about, and cognitive biases and diagnostic errors. Now, I'm about to finish my presentation, and this will nicely link to the presentations that will come after mine. The third Sustainable Development Goal asks for universal health coverage by 2030. We like to add the term of safe universal health coverage, because it's not just about ensuring that everybody has access to health, it's about ensuring that everybody has access to safe health. Because if we don't focus on the safety of healthcare provision, we will just be adding more harm to the care that we already provide. And if we look into the number of healthcare professionals needed by 2030, it is said that the world will need around 80 million healthcare professionals. And this is it's a global concern specifically for nursing, where the State of the World's Nursing Report launched by ICN and the WHO tells us that 40 million new nurses will need to be educated and employed by 2030 to maintain the status quo. So not even to really make it better, it's just to maintain what we have. And this is quite important for nursing schools, because as we have 5 million nurses that are older than 55 and they are set to retire by 2030, we have 6 million new position nurses needed based on population growth and changing of the health needs and demographics to meet the global health targets. And we have 3 million nurses that were affected by COVID, and we really don't have this number quite certain yet. So this is, it's just one of these patient safety concerns that I've raised, which is a staffing shortage, probably one of the most important ones so far. By 2020, we were already shortage of 18 million healthcare professionals in low middle income countries. And I like to say that during the next pandemic, healthcare systems, they won't be fighting for masks or ventilators, and they will be fighting for healthcare workers. And therefore it's urgent, and it's really a global concern that we look into preserving those healthcare professionals that are still in the workforce and to ensure that we have new ones wanting to join us. A global solution could be, just to finalize, it's the power of global advocacy or the lack of it. Those three slides, again, they're very simple, but they tell us that for the last 20 years, because of the power of global advocacy for HIV and malaria, you can see that the number of people that have died actually decreased, whereas the lack of awareness and advocacy for healthcare safety for the last 20 years have actually allowed for unsafe care to increase significantly. So this is where we can see that if we really get together globally into tackling this issue, we can actually, hopefully we'll have another graph for unsafe care going downwards instead of upwards like this one. So thank you very much. I hope I wasn't that far from my time, and I'm open to questions or comments or any additions I'd like to have to my talk. Thank you very much.
Thank you very much, Dr. Sofia Macedo, for your presentation. Just to briefly remind our participants that we will have a slot for questions and answers at the end of all presentations. So if you have any question, please write it on the chat, the question, and also the presenter to which you want to ask. Dr. Sofia Macedo, your presentation was very interesting. It was about a complex issue within the healthcare area. It's not only a global concern, but also individual concern, right? So you spoke about healthcare safety in numbers, treating, but also preventing all issues related to it. And it was very interesting to hear also that behind numbers, there were faces, or there are people behind all the numbers and statistics that you briefly mentioned earlier in our presentation. And it was also very interesting to hear about the contributing factors for unsafe care, like organizational system readiness, overwhelming workload, time pressure to decide, which are those variables and factors to which managers and institutions should try to fight about. And also, of course, not only individual patients, but families are victims. And at the end, an interesting link to the Sustainable Development Goals and the proposal to create a new goal. It was very interesting. Now we will have Dr. Anabela Coelho. Dr. Anabela Coelho has a PhD in international health. Is a healthcare quality specialist, a patient safety expert at the OECD, head of quality management unit at the Ministry of Health from 2005 to 2019, currently an assistant professor at Lisbon School of Health Technology. Dr. Anabela Coelho, thank you very much for your presence.
Thank you so much for the kind presentation. First of all, I would like to thank the organization for the invitation and give a special thank to Sofia Macedo for the trust placed in this presentation. Second, welcome all the participants, wishing that this webinar fulfills your objectives and your interests. As you can see, I have defined a very ambitious agenda for this session. Start, I would like to share with you the main concepts and new thoughts about patient safety. Then I will go directly to the international data regarding the patient safety culture. And at the end of this speech, we will focus on the Portuguese patient safety strategy. So firstly, I would like to share with you some concepts and food for thoughts regarding safety culture and patient safety. So the traditional assessment of patient safety have focused on the quantity and severity of the patient harm, such as medically acquired infections or adverse drug events. However, there is a growing evidence that strongly supports that this idea, because not enough. Measuring what goes wrong in healthcare is not enough for us. Healthcare systems require measures that assess their capacity and ability to deliver safe care. This is why measures of safety care culture have been increasingly using the understanding of the presence of the absence of safe organizational environment.
Dr. Anabela Coelho, I'm very sorry to interrupt you. We are having a bit of difficulties to hear you. I don't know if you can try to improve your sound.
What to do?
Are you using headphones?
I'm using the microphone on my camera, so probably if I came a little bit more near my camera, you could hear me better. Let me know, please.
Okay. Let's try. I'm very sorry. Please continue.
Okay. So as I was telling you, healthcare systems require measures that assess their capacity and their ability to deliver safe care. This is why measures of safety culture have been increasingly to understand the presence or the absence of safe organizational environments. Instead of attributing blame or for failures to individuals, many health systems now focus their improvements in systematic and organizational characteristics that are necessary for ensuring policymakers are moving their attention to risk mitigation, learning-based health systems, and healthcare environments design that takes into account the human factors. So we can all agree that patient safety culture is a fundamental component of these efforts. The term safety culture has been used across different sectors, from high-risk industry like aviation, energy, as Sophia has already highlighted in her previous speech. And the concept came into prominence in the aftermath of Chernobyl nuclear disaster in 1986, where the major safety culture lags were identified as the root cause of the accident. While there isn't international agreement on the definition, safety culture tends to describe the static and unwritten rules that seem to guide the actions of groups of people within another organization. As you can see, another common definition recognizes that safety culture is both structural and attitudinal, and it is also related to the organization's culture and style, as well as related to attitudes, approaches, and commitment of individuals at different levels in the organization. So, colleagues, when we go to the healthcare theater, what challenges are expected in this mainstream environment? Patient harm is estimated to be the 14th leading contributor to the global disease burden. And when we get closer and analyze data from low and middle income countries, we find that patients harm bear over half of the burden. In the countries, patient harm and adverse events account for 15% of total hospital expenditure, representing a considerable drag on of the healthcare system. So, a strong patient safety culture is an essential component of several healthcare systems. Positive patient safety culture is characterized by a collective mindfulness about patient safety issues, mutual trust among staff, shared responsibility for safe care delivery, as well as confidence in organizational level safety initiatives. In other words, developing a strong patient safety culture means creating a collaborative, safe environment where performance, and patient safety are a shared value and a common goal. Let's go now to international reference about patient safety and about patient safety culture and get the big picture of what is happening in several countries worldwide. Since 2005, the OECD has collected several patient safety indicators for international cooperation from hospital sector and primary health sector. The following discussions by the OECD Health Committee in 2008 determined that the existing patient safety indicators collected by the OECD were important, but not enough. Support was given to measure the safety culture and also integrate the patient voice in reporting safety experiences. Measure of patient safety culture from the perspective of healthcare workers can be used along with traditional patient safety indicators, health perspective, health outcomes indicators also, patient-reported experiences, and give us an holistic perspective of the state of the safety in healthcare system. Improving patient safety culture is a priority for the OECD countries as they work to improve healthcare quality and safety. And this goal has increased in importance as countries have faced new safety concerns related to COVID-19. Findings from benchmarking work in so there is sorry. So let's check it together. Regarding the staffing levels, just 2 in 5 survived health workers in staffing levels at their workplace are appropriate for human safety. Countries where the fewest health workers have a positive perception of staffing levels include Japan, France, and Portugal, my country. Survey findings from OECD countries indicate that only 46% of health workers believe that important patient care information is transferred across hospital units and during changes. Effective handoffs and transitions are important for continuity of care, and half of the countries, where is Portugal included, believe that information was sufficient. Only 1 in 2 healthcare workers believe that their hospital management provides a work climate that promotes patient safety and shows that patient safety is the top of priority. And the state can freely speak to colleagues and authorities about patient safety issues in their profession. While we were thinking about this data, I would like to say that this benchmarking reveals heterogeneity. And how health workers perceive patient safety in their work environments. For example, the difference between staff's positive perspective of safety regarding management support for patient safety and communication openness differ from 50 percentage points between the highest and the lowest performing country measurements. However, this national benchmarking is a critical and useful addition to the existing measurements initiatives on safety culture and helps to accelerate the necessary change. Collaborative efforts are not only but they can also move perform sharing best practices internationally. To conclude, I might say that there is a great opportunity for countries to capitalize on the linkage of patient safety culture with other key metrics such as safety, climate, health work safety, health work resilience, and patient-reported experience of safety. So regarding the Portuguese patient safety strategy, I can say that a long effort has been done since 2009, when we have established the first ministerial department for quality of health at the General Directorate of Health. Then the Portuguese government assumed the responsibility of planning and monitoring the critical areas of quality and safety in all the national health service. The legal framework determines that all the public healthcare providers should ensure through their quality and safety conditions, the protection of the quality and safety plans, and ensure good management of involved. In Portugal, all the hospitals and primary healthcare units should implement patient safety culture survey. Since 2015, as the national legal framework was implemented to establish the first national plan for patient safety. However, this mandatory request wasn't 100% observed. Additional to all the data already shown where you can see Portugal, we have a 2020 goal of the national patient safety plan not achieved, related to the responses rate the patient safety culture survey. However, as you can see, healthcare workers and primary healthcare units have an increased regarding the average of positive responses for all the 12 dimensions provided. Once again, the primary healthcare has higher scores of positive answers, supplanting the goal of 50% of positive responses for 2020. Finally, 1 minute to share with you our predictable next steps in this area. It is expected that the legal framework published in 2021 will embrace new challenges expressed by this new national plan, Phi-Xi plan, in 5 pillars, which are patient safety culture, leadership and governance, communication, prevention and management of adverse incidents, and safety practices and environments. The pillar patient safety culture has 3 strategic objectives related to the healthcare training on patient safety culture assessment and regarding the patient safety leadership. So to finalize, I would like, and I wish that you all have a great use with the work that is expecting for us, and wishing also that the challenge for us here in Portugal will be and also other colleagues worldwide that
Thank you very much, Dr. Nevalquale, for your presentation. Although sometimes the sound was difficult to understand, not many times, the slides were very appealing and informative, and the topic is very, very interesting. So you presented us the perspective of Portugal, a worldwide perspective as well, a presentation more focused on patient safety culture. And it was very interesting to acknowledge concepts and the new paradigms associated with this topic, patient safety, and these new paradigms being, for example, learning-based health systems, risk mitigation, human factors, which is something that is innovative and new to many research studies. It was something that filled my eyes at the end of your presentation was the big picture in numbers. About the 46% of the surveyed health workers believe that it's important, that important patient care information is transferred across shifts, and maybe we should perform more awareness sessions for professionals and institutions. And at the end, it was very interesting also and exciting to get to know the 5 next steps explained in the National Plan for Patient Safety. So thank you very much for your presentation. It was a pleasure. Now we will have the next presentation, Dr. Teresa Beeson. Dr. Teresa Beeson is a registered nurse, also Fundamentals of Magnet certified, currently an executive director of nursing operations at the Ministry of Defense. Thank you very much for your presence, Dr. Teresa.
Thank you so much. You can see my slides and I'm hoping you can hear me.
Yes, very well, thank you.
Great, thank you. So my presentation is on civility as it relates to the nursing profession and safety. And I'm going to I'm working on advancing the slides there. I'll spend quite a bit of time talking about civility and incivility and really trying to hone in on the impact of safety for nurses, safety for patients, and how it also the impact on the healthcare organizations. If at the end I have a little bit of time, I can talk about a framework for a culture of civility, but I think it will get a little bit tight at the end because I have a lot of information and I tried to cut it down as much as I possibly could. So when we talk about civility, we first have to define civility and incivility. And I don't know if the term civility and incivility are being used in Europe right now, or if they're being used in Portugal. In the US, especially in published literature, the terms have been taking on greater traction in the last 10 to 15 years. And in Saudi Arabia, we have a very multinational workforce, and we have nurses from sometimes 20, 30 different countries working in organizations. And we questioned whether or not we could use the terminology, but we have been able to introduce it, and our multinational nurses have been able to integrate it, which has been amazing because it's not a normal word. Even English is my first language, and civility and incivility are not words that we use on a daily basis, and I don't use on a daily basis when I'm in the US. So to define civility is simply very clear and simple definitions, which are being polite, displaying genuine courtesy, and showing respect, and being professional or demonstrating professionalism. Now, the Tri-Council of Nursing, based out of the US, has called upon all nurses to recognize nursing civility and to take steps to systematically eliminate all acts of incivility in their workplace. And the word systematically is very key, because incivility or bullying or lateral violence, whatever your organization calls it, is so endemic and entrenched within nursing for decades and decades that it does require very concentrated and very structured and purposeful activities to eliminate it. So when we talk about that civility, so we want to then go into what incivility is. And I'm not going to go through the details on this slide, but it just shows all the terminology that we have been using for the last 20 to 40 years to talk about what is the inappropriate or the disruptive behavior within nursing. Lateral violence and horizontal violence actually stem their definition in nursing published literature. You can see that the word nurses are in the actual definition of lateral violence. We typically spend most of our time talking about bullying and harassment because it's in the movies, it's in our daily language that we speak. And I just want you to focus on all of the red words. Those red words are very charged words and egregious behavior. They are really on the far end of spectrum when we talk about what is not acceptable behavior in the workplace. So the definition of incivility, which just popped up on your screen, has no red words whatsoever. And that is because it is the lowest level of behavior that should not be tolerated within a workforce. And the definition is low intensity deviant behavior, which can be as simple as being rude or discourteous. And it's either has the intent or possibly not even the intent to harm the target. But one of the things I want everyone to focus on is that it may be a single event. If you look at the definition for bullying, in the definition of bullying, it has to be repeated behavior. So when you think about a nurse who has the courage to speak up for himself or herself, and they essentially say that something is not going well for them or they're being treated in an inappropriate manner at work, a lot of times there is dismissing of it or minimization of it. And people will say, it's a one-off, it only happened, we've had a really busy day, the case was really hard, the surgeon has a lot on their plate. People start making excuses. And what happens is that we ask people to allow one-off events and we ask them to just let it go. And this is a big issue because if your organization uses bullying and uses it per the actual definition in the literature, it means that people and nurses or healthcare workers should allow for repeated inappropriate behavior, which is where we don't want to be. Because there's a huge trend right now, and actually I'll get into it on this slide, is that globally we know that workplace violence costs 4 billion euros per year and 1,000 healthcare workers' lives annually. And even though this is a 2006 publication, it does specifically talk about incivility, and it talks about this initial minor incident, and we're going to refer to that as a single event. So if a single event, initial minor incident of incivility could be mitigated in an organization, the financial and the human capital that could be realized by the healthcare organization is immense. So the trend is very clear. There's a huge movement to deal with even one single or one-off events. We have to acknowledge that incivility is actually the slow death of the nursing profession. At the introduction today, the famous saying, as always for healthcare, which is first do no harm. The first do no harm is with the code of ethics for nursing, but it also should be the first harm that we don't do is for our colleagues. And the ANA and some organizations have expanded the definition of incivility and including it to say incivility includes failing to act when action is warranted, failing to speak up when indicated, or refusing to assist or support a coworker, even when it is related to incivility. Nursing is a profession of compassion and empathy and altruism, and that extends beyond our patients it extends to our colleagues first and foremost. So again, a lot of times we're asked, why do we need to use new terms when we have all of these other terms that we've been using for decades? And so the argument that I like to make is that when you start with a definition of civility and you know what you want to promote within your organization, then you simply are setting the foundation, and it's a positive foundation. And then after you've defined civility and you've promoted civility, then you can start defining what incivility is and how you're going to address incivility. And then at the top of the pyramid, you have a very small section of your organization that has to deal with bullying, abuse, harassment, and violence. If we don't adopt the terms civility and incivility, what happens is we're left with all of the other terms. And if you go by the actual definitions, you can see all of those red words mean that we are so far on the other end of the spectrum. And when you're on that end of the spectrum, it's so entrenched and it's very hard to pull back and come into what is normal behavior within an organization. So within nursing, it does not matter what terminology is actually used. Incivility is a reality for all nurses. It is the core of an unhealthy and an unsafe work environment. Its negative impact reverberates throughout the organization, and it is endemic within the profession. What that means is it doesn't matter what country you work in, what sector within your country, what hospital, or what unit within your organization. Every single area has issues with incivility. So we want to know, what does incivility or lateral violence look like in nursing? And again, for the interest of time, I'm not going to go through all of these, but I just want to bring your attention to refusing assistance, allocating unrealistic workloads, hoarding or hiding supplies, deliberately withholding information, and deliberately setting up another nurse for failure or sabotage, or excluding because of communication, which is very common in a multinational workforce. And when you go back to that definition, the expanded definition of what does it look like, what does incivility look like when someone isn't standing up and we have silent bystanders, is that think about the nurse who doesn't get full handover, think about the nurse who cannot ask for a double check for a high-risk medication, doesn't get help in turning and positioning her patients, basically has an unfair workload, and how this plays out on a shift-by-shift basis for nurse safety and for patient safety. Now, all of these can either be overt or covertly displayed, and I like to go to an iceberg analogy because the overt or the visible is what we see, and we usually think of this as aggressive communication and shouting, and it's often the physician at the nurse's station and there's witnesses. So even not to minimize physician to nurse incivility or aggressive communication, but it is one of the more easier ones to deal with because there's always witnesses. We know from published literature that nurse to nurse incivility is more common than physician to nurse incivility. Although when we continually ask nurses, where is the biggest, who are the perpetrators? They will always say the physicians, the physicians, the physicians. But it is underneath that iceberg, which is the nurse to nurse incivility, which is the manipulation of work, withholding information, refusal to communicate, isolation and sabotage, which is very hard to report because it's hard to validate, it's hard to address, and it's happening in our patient care areas. And it's happening on the off shifts and the weekends. So there is something that is referred to as the insult to injury spectrum. And what happens here is civility is on the one side and abuse is on the other. And no perpetrator or abuser starts off with abuse or high-risk threatening behavior. Everything starts with low-risk behavior, and the perpetrator or the abuser, I know that those are very legal terms, and they're sometimes I'm asked not to use those terms, but I don't know what else to use for the presentation, is that the abuser will start with low-risk behaviors. They want to see, does the victim speak up for themselves? Does everyone around the work environment allow it to happen? And when it is allowed to happen, it will always increase. So incivility occurs on a continuum. It follows a natural progression from low risk to high risk when left unaddressed, and it will always repeat and escalate if it's unaddressed. And I mixed around some slides for the timing, but there was a study done in Saudi Arabia with 500 nurses, and it's a little bit old, from 2002, and I use it as an example because when you put together a civility program, what you're going to see is that in this survey in 2002, 92% of the nurses said that they have had harsh, insulting language used with them. 38% reported verbal threats, and 16% reported actual physical assaults, which is very consistent with the published literature from Western countries. And when you put in a program that defines civility and deals with incivility at the lowest level, you would hope that you would be able to reduce across the spectrum, which is that if you can reduce from 92% to 60%, then you would see your verbal threats decrease. When you decrease verbal threats or threat of harm, you would actually decrease actual physical assault. And we'll go into those numbers a little bit later. So again, nurse-to-nurse incivility is the most common. We know that some nurses in our facilities experience weekly or even daily bullying or incivility. And we know that all new nurses experience incivility within their first year of practice. And when we talk about the impact, we know that 90, or some people can say 100% of nurses will somehow be bullied or have incivility at some point in their career. And whenever I do this presentation, all of us on this call, which is close to 50 individuals, have our own stories of what has happened to us. And sometimes we have to have insight on whether we have also been sometimes perceived as the aggressor or the abuser. And we know that there's a huge emotional and physical toll that happens on the nurses. And this is translated into the work environment with stress-related illnesses, job dissatisfaction, disengagement, low morale, excessive sick time, loss of productivity. And at the very end, it's this lack of passion for the nursing profession, which is the slow death that we are contributing to our own profession. We do know that 100% of the patients are at risk. We talk a lot about patient safety. Civility is the foundation of patient safety, but almost every conversation about patient safety, and I understand Sophia wants us to use healthcare safety now, which I'm going to try to acknowledge within my presentation, is that we talk about bundles, we talk about initiatives, we talk about programs, we talk about reporting, incident reporting, we do culture of safety surveys, but very few conversations talk about what's happening underneath that iceberg. What is happening on a shift that makes it very, very difficult for nurses to provide safe care, to be safe themselves, and to promote healthcare safety. We know that nurses who are stressed by the effect of a hostile work environment are more likely to make errors. And we know that problematic interpersonal communication is indicated or a contributing factor to 60% of medication errors and 80% of overall medical errors. And this study the last one is from 2019, and I wanted to highlight that the words incivility and civility are being used more and more in published literature for nursing. And they found that not only that we know that the effects of an uncivil work environment are those nurses are less likely to even respond fully to the needs of their patients, which is very concerning. And they are actually less likely to speak up if there are safety concerns. So when we talk about speak up campaigns and incident reporting, we have to acknowledge that civility is the last link to quality. And it's the one that hasn't been fully addressed yet. There are some recurring themes of incivility, specifically in the nursing literature. And one is that behaviors are minimized or not recognized. And again, that's the one-off, just it only happened once to you, just let it slide mentality. There's a general lack of awareness and no clear expectations for civility and no clear expectations for incivility. And we have possibly too many silent bystanders, and the victims are left, if I can't intervene for myself, who will intervene for me? The fear of retaliation is very significant within the organizations. Nurses make calculated risks. If I can't report it, if I'm not believed, if my manager or leadership can't address it, then it will only get worse for me. So many nurses will simply suffer in silence because it is a calculated risk for them that their situation will be better if they don't speak up. But it really comes to trust and competency of managers and leaders to deal with it. Avoidance and isolation become the norm for coping strategies. And at the end, there's organizational chaos. And organizational chaos means that patient safety and quality KPIs cannot be achieved. And there's this huge negative impact on nurse safety and patient safety. And for the organization, the costs are enormous: ongoing patient safety concerns, costly medical errors, patient harm, healthcare worker harm, significant increase in just the basic delivery of normal patient care, and a revolving door of orientation. We know that incivility, again, both our 2019 publications focusing specifically on incivility, it negatively impacts nurse satisfaction, well-being, nurse turnover, patient safety, and the quality and the cost of the delivery of care. We know that the cost of turnover for every 1% of annual turnover costs a hospital 285,000 euros. The average turnover of a hospital in the United States is 16%, costing each individual hospital annually approximately $5 million US, or equivalent to 4.7 million euros. We know that replacing nurses is very costly, and replacing a specialty nurse can be up to 135,000 euros. In terms of, I think I'm okay on time. Okay, so in terms of creating a culture of civility, it is a very long road, and simply put, the end goal is to prevent issues and then to resolve issues that actually occur. And you want to be able to do that at the lowest level, and that is the unit level and the individual level. But that means that nurses have to have the tools, and they have to feel empowered and supported to do this. And you want to find a solution as soon as possible to the satisfaction of both parties with no retaliation. And what this means is an enormous amount of staff awareness, training, and everyone needs to be engaged and committed to prevention. The staff need to be confident in themselves, in their coworkers, and most importantly, in their leaders, that when they report something, it can be addressed effectively. And we're always seeking a resolution, and it can be informal or formal, and every organization should have a combination of the two because they support each other and work in tandem. And the most important is that there's no retaliation for the nurses. And once the momentum builds that people do report and there's no retaliation and there's success stories, you don't even need to talk about them because the nurses talk about them within themselves and they figure out which managers and who is supporting them. When we talk about who are the players of incivility, there are three: the instigator or the perpetrator, the target or the victim, and then the observer or the bystander. And oftentimes the bystander is silent. It took, even though this is 2012, it took me a very long time to find literature on the traits that emerge among abusers. And it's quite significant. They are typically seniors who feel privileged and protected, either protected by administration or physician colleagues. They lack insight into their behavior, and almost always they are seen as excellent or this or that. They are typically the clinical experts on the unit. And this is what makes it very hard when they feel protected and others feel that they're being protected by other individuals in the organization and they are experts, that it makes it very hard for the victim to raise any concerns. But we do know that when victims can advocate for themselves, they do feel empowered, and it's a very important mechanism for them to have. But research is continually showing us that the key is to empower the bystander, that when the bystander on the shift that is being worked, let it be a day, weekend, night, or off shift, that if the bystanders can advocate for the victims or partially even address the perpetrator or the abuser, that this is the game changer for civility and promoting civility on the unit level, at the level of patient care. And I want to go back to the iceberg analogy for a second. If you take this slide and you remove the word problems and you put in incivility, we know that top managers of a hospital only know 4% of the incivility that occurs. The nursing supervisors probably only know 74 to 75% of the incivility that occurs. The people or the individuals who know exactly what is happening, who gets the incomplete handover, who is refused assistance, who is being sabotaged on a daily basis at work, is these three individuals. Every shift that's worked in the hospital, the individuals on that unit fall into one of these three categories. They're either the abuser, a victim, a potential victim, or a bystander. And the most important thing is to have bystanders be active. And the literature is supporting this more and more. So in terms of a culture of civility, I will put all the elements in place, but I want to focus on the baseline data and conducting an annual civility or an incivility survey. And within our organization, we have about 12,000 nurses over 20 different hospitals in the kingdom. And we conducted a survey in August of 2021, where we had 8,000 of those nurses respond. And we used a published tool, and it's been published twice by the same author group. And this really was a game changer for us, because it, instead of presenting data from Western countries and instead of presenting data from past studies published in, even though they are published in the kingdom or in the Middle East, once our nurses started telling us what was occurring to them, it became truly actionable data for our senior administration. And it was the catalyst to put together a very robust culture of civility program. And I just want to give you some of the questions that we modified slightly, but they came from this published literature. First, it started out with how often are you treated with courtesy and respect? So we measured the civility, we measured the positive foundation that we wanted to have. And then we needed insight, is how often do you lose your patients? How often have you ever done anything that crossed the line? Because we cannot all be the victims in this. We are sometimes the perpetrators. And then we measured how safe our nurses feel about retaliation. And then the final product is giving our nurses tools and empowering them. So we want to give them training, and on an annual basis, we want to know, is that training being effective? And the last question is the question 11, which is that, have you seen or observed a coworker having lateral violence or incivility or bullying? And this is the measurement of how much do we have bystanders who are not able to or not comfortable yet to advocate for their coworkers. So the program that we have been attempting to put together, and I think for the interest of time, I can't go over all of it, and I won't. But number 5 is something that is really key, which is that the leaders cannot be the perpetrators, and they must support and model civility. And the leaders from the nurse manager up have to be able to be competent to address it. And if we are not competent to address it, the nurses will not report it. They will not trust us to be able to resolve the issue. And so this is what the Culture of Civility program that we are working on, and we're trying to put it more together in 2022. And again, repeat the survey that we conducted in 2021. So I think I'm okay for time. I think I had 2 minutes left.
Yes, 2 minutes more.
Okay, so actually I did better because I was at 22 when I practiced it. So really the last message is that one of the biggest issues why incivility or bullying occurs is because it is modeled by the wrong people within the organization, and simply because it is left unchecked by bystanders and unchecked by leadership. And it can have, as I mentioned in the presentation, it has a significant effect on nurse safety and patient safety and organizational culture. So with that, I will end on time. Thank you so much for the opportunity.
Thank you so much, Dr. Teresa, for your presentation. Somehow, civility, a different approach to the topic until now, very interesting. I myself didn't realize until now how emerging and important this topic was. Actually, someone here, a participant in our webinar, also told that from the perspective of someone who has already experienced in a diverse clinical context, this presentation is extremely important and accurate. And yes, very interesting how you puzzled the incivility in nursing has violence, bullying, harassment, discrimination, And the idea that it's the slow death of the nursing profession is very, very interesting, as we nurses incorporate and should incorporate humanity in our care. So that's really a core concept to nurses profession. And when somehow you fall in incivility, I think you undress your nursing cloth, and which should also be within you, not only a mask being a nurse. And yeah, also the insult to injury spectrum, like a way to objectively frame incivility, starting with low risk behavior and then developing into high risk behaviors, which highlights the importance to prevent and to be attentive to what's happening to each nurse. And then the 90%, the number 90% of nurses being bullied at some time in their career, it's somehow worrying, cumbersome, and uncomfortable. It's an uncomfortable number. And yeah, this topic demands a huge commitment between professionals and also institutions and patients and caregivers. Thank you very much, Dr. Teresa.
Thank you so much. It's my pleasure. I'm going to mute myself, but I actually am going to share Ms. Mawaheb's presentation.
Okay.
So I just need a couple of seconds to be able to pull it back up. So if you can give me just a few minutes,
yes,
hopefully just a few seconds. I just have to get it into the PowerPoint, the slideshow mode.
Okay.
1 second.
Maybe I'll present Dr. Mawahib Wang, a registered nurse, currently an executive director of nursing administration at the Ministry of Defense. And the topic is a reflection on the journey to safe staffing regulation in Saudi Arabia. So until now, we've been talking about worldwide, then we talked about Portugal, and now we are going to another specific context with Dr. Mawahib. Thank you very much for your presence.
Thank you very much. I want to first thank you, Dr. Felipe, Dr. Annabelle, and Sophia for giving me the chance to share with you our journey in Saudi Arabia toward safe staffing. I think every single country, especially right now after the pandemic, suffers from shortage of nursing. And it's very important as nurse leaders that we ensure the safety of our patients, but also at the same time, the safety of the nurses. And I think nurse safety comes before patient safety, because an unsafe nurse cannot provide a safe care, which is what healthcare is all about. So with this, I would like to share with you how the transformation happened. Transformation in Saudi health system started late 2016. The country had drafted a proposal to divide the healthcare Ministry of Health into different clusters, which they divided into 6 clusters in the country. The first cluster was established in the Eastern Province, and it included 22 hospitals and 148 clinics. At the time, I was a CNO in one of the hospitals, and all of a sudden, I had 22 hospitals instead of one hospital. So in this, it was an eye-opening experience. Never held a job with the magnitude of 22 hospitals, not knowing what happens at every single hospital. So in one of the journeys of the new hospital that we took over in Ministry of Health, I was visiting a hospital, and when we walked in one of the units, the CNO of that hospital and myself, there was a young nurse that was sitting at a desk. She was documenting her notes and didn't hear us come in. So I tapped on her shoulder and I said, "How are you, my dear?" And she started crying for 20 minutes. We didn't know why she was crying. And finally, when she stopped crying, I said, "What's wrong?" And she said, "I have 30 patients. I have 30 pediatric patients." That was the sentence that actually ignited and started this journey of safe staffing. So Teresa, can we go to next, please? So when this nurse said that she has a concern that she cannot give a safe care, nobody can, not even a superhero can give a safe care for 30 patients, let alone pediatric patients. It is just the system was setting up for medical errors to happen with that number of staffing. A huge journey started right then and there. You know, we talked among ourselves, first of all, as healthcare leaders, as nurse leaders, and different stakeholders were brought into the system to help how we can solve this issue. Next. So it started, you know, with let's look at what is the evidence out there. So we did a review of the evidence. We saw that inadequate staffing always leads into many errors: hospital-acquired medical errors, hospital-acquired infection, such as failure to rescue, definitely infection like COTI, CLABSI, and VAP has all shown a link to staffing. Also, we saw that when a nurse have too many patients, they have higher incidences of pressure ulcers, which definitely makes sense because the nurse has no time to take care of her patient or to turn the patient. And the mortality rate increased because simply the nurses don't have enough time to spend with their patient to do the proper assessment and recognize anything that is going wrong. So with this, we see we can do a whole webinar on the cost of medical errors because of lack of staffing on nursing. And I think we should do that. We should speak in the language of how do nursing bring value, money value to the healthcare. Only then the decision makers and the governments will start to understand. And we saw that when we have a higher number of patient to nurse ratio, the nurses get frustrated, burnout, and they leave the profession. So let's look at some of the evidence that was presented from 2002 all the way to 2020. There's evidence that present that when a nurse, Atkins was one of the first who started this research, and she documented that every single patient that you increase in a surgical patients, the mortality rate increased by 7%. And every single nurse that you give extra patient to, you get higher risk for sepsis, for shocks, for bleeding, just because the nurses don't have time to take care of the patients. Also, with every single patient that is more than 4 patients per nurse, the risk of CPR increased by 16%. In the intensive care unit, when we do adequate staffing, which is 1-to-1 to 1-to-2, we see that the risk of CLABSI decreased and 60% lower CLABSI rate. That is not only saving money for the hospitals, it's saving lives. And we saw the effect of the safe staffing in California. What happened after California had safe staffing? We had increase in nursing satisfaction. One of the best satisfaction in nursing is in California. We also saw the effect that it had in Victoria when 20,000 nurses after the implementation of safe staffing went back from retirement, they went back to nursing. So there is a mountain of evidence that shows that if you give the nurses appropriate number of patients and according to their skills, it's not only about numbers, it's also about the experience. You cannot put, for example, 4 new nurses to take care of all the patients in the unit. They need reference, they need people with experience to get the support from. Next. So I'm going to actually share this with you. In 2018, the ICN had put out a statement about safe staffing. So it says, ICN says safe staffing and nurse staffing are 2 sides of the same coin. Like we said, if we nurses are not feeling safe and satisfied, they're not going to give good care. So we cannot expect safe patient care with inappropriate nursing, whether it is the education inappropriate, the experience inappropriate, or the numbers inappropriate. Next. So as you can see in this photo, you see Sophia right there standing to Howard, the president of ICN, and then there's Tedros, and there's myself standing next to Tedros, and then there is Miss Teresa, which is the first time I met her in that ministerial global summit. So in the ministerial global summit, we proposed an action plan. One of the people that was there is also the founder of IHI, Don Berwick, is standing there in the corner. And we presented an action plan to say that we are going to be working on safe staffing. And from there, next please, we started to put together a white paper that was composed from different experts, including the Patient Safety Center, where Sophia was working at the time, Teresa Basin, myself, and other experts put together a white paper that was endorsed by ICN, and it was presented in 2019, next slide, in the ICN conference. So before we did that, we had to make sure that we endorse this from legal perspective. So the first place we went to was the Nursing Association, Saudi Nursing Association, and that's the president, Dr. Mohammed, sitting there. The one in the middle was the CEO of the Patient Safety Center, and the one on the right was the CEO of the Healthcare Commission, which gives all the license to all the healthcare professional. They did the endorsement for that, and that was the beginning, the legal beginning of this journey. And then, next please. And then the white paper was presented in Singapore in 2019. After that white paper was presented in 2019, then, the next slide, we put together a group of experts from all sectors in healthcare. So in Saudi Arabia, we have different sectors. We have the Ministry of Defense, Ministry of Interior, Ministry of, and then local private hospitals and Ministry of Health, all got together, and we came together with appropriate nurse-patient ratio that is suitable to our country, but at the same time is evidence-based. What we have to keep in mind is the more diversity that you have in nursing, the more you need to make sure these nurses are equipped with the education that they need, with the experience to take care of different patients. So with these experts over almost a year took to propose the nursing ratio that was then later endorsed. Can I have the next one? Was endorsed as an official paper, as a guideline that that outlined exactly every different specialty, how many patient a nurse can take care of. So we didn't only look at nursing, we looked at midwives, and we looked at different, we included even some patient experts, we included some administrators to take their opinion, and we came up with these guidelines. Then next. Then the Saudi Central Board of Accreditation Institution, which is called Sabahi, which is like JCI in the US, which governs all the accreditations, adopted the ratio and made it part of the accreditation process. Our journey in nursing inspired many others. It inspired the physician, it inspired the other healthcare clinicians. So they all, in the critical areas at least, and in the inpatient, came up together with a minimum ratio for the healthcare people. So for this example, in the OR, they came up with a minimum number of anesthesiologists help, In the ICU, they came up with how many register has to be there, how many consultants have to be there, how many respiratory people have to be there. So the journey for the nursing has inspired the entire healthcare to try and put together guidelines that will make healthcare delivery safer. Next, please. So the journey timeline, as we discussed, started with the ICN statement in the 2018. And then in 2018, we had initiation of the work, and the fourth Global Ministerial Summit happened in March 2019, and that's where the action plan started as a countrywide to make this as a regulation for the country. In April, the next year, the first white paper came in. That was the backstone for that. And then we got the endorsement from the first three governmental institutions. Then the initiative started in 2020, and it took about a year. Can I have the next? To get it done. And the final documentation came out in August 2021. Then in December, the work started with making it part of the regulation for the hospitals. So for example, if the regulatory body went for accreditation in a hospital and they find 30 patients, like we found earlier in one hospital, the hospital will be given citation that, you know, they're going against the regulation. And I think unless we actually put things in the policy, you cannot guarantee that hospitals will voluntarily follow guidelines, because those guidelines were there. So why did we see 30 patients to one nurse? So in 2022, the guidelines is going to come out. It's been finalized, but they're reviewing it. In 2022, the implementation is going to start this year. And next slide. These are the bodies that accredited and helped us make this happen in nursing. And I want to acknowledge the people that work together in this. Can I have the next slide? Yes, as you could see, there are so many people over there. All of them really contributed their expertise in nursing and in healthcare in making this regulation come to life. So a tribute to all of them. Thank you very much.
Thank you very much, Dr. Mawahib. An interesting presentation about the specific perspective in Saudi Arabia, the journey to staffing, nurse to patient ratios, which is very important. And when I read the sentence, I have a concern, which was the initial step. I immediately thought of the importance of talking and the courage of meeting the problems and trying to find the possible solutions. So the importance of talking, the importance of finding the problems and the solutions. Also the importance of the evidence and the respective implementation of the evidence in practice. Also interesting output of your presentation, and also the importance of engaging all kinds of stakeholders and making them understand the real problem and the hazardous effects to institutions, but particularly to patients of the poor ratios. And also the guideline, which you've closed your presentation, the guideline that was developed together with the Central Board of Accreditation for Healthcare Institutions. So thank you very much for your presentation. It was a pleasure to have you with us. We have now around 20 minutes for a short question and answer slot. I don't see currently questions in our chat, but I have some questions that I would like to ask. The participants might also write questions now, but while there are no questions, I will start if you mind. So the first question is for Dr. Sophia. Dr. Sophia, when I read, and I did read some years ago when it was released, the To Err is Human, the report, I thought, and after your presentation, that errors will exist as long as humans exist. So that's the premise of this report, To Err is Human. So my question was, how could technology and innovation, which is something that is very present right now in research and in the society, how technology and innovation could help avoid errors? Because the report talks about how information technology might be a tool for measuring and understanding quality issues, for example, but what about interventions? What about, and the risk that technology might pose in substituting the profession, which is also something that is not that's good. So I hope you understood my question. Thank you.
Yes, I did, Rafael, and thank you for that question. When we talk to hospital executive directors, usually we have that kind of comment as well. To err is human, and as you put it very well, as long as healthcare it's managed by humans, to err will always be there. What we want to do, it's not to completely eliminate error. What we want is to eliminate the harm caused by potential errors to patients. And again, not to patients only, to patients, to families, to the healthcare professionals, as we've heard throughout the presentations. And I couldn't agree more that, and this is why I tend to go to healthcare safety, because until we get healthcare professional safety right, we will always put patients in jeopardy. So answer to your question first is errors will always be there. What we need to use is technology, and not just technology, but also approaches as simple, and I want to put in brackets simple because it's not simple, but that are related to human behavior, like civility or to tackle incivility. So it's not just about technology, and we all appreciate the advances that has given us, but technology won't do anything for us until we actually tackle more fundamental human behaviors that are associated to the healthcare profession. So it's the harm that errors put into reality that we need to tackle. And I'm going to bring you a statement or a conversation I usually, my previous CEO from the Saudi Patient Safety Center, Dr. Hussawi, and I'm sorry, my dog just lost it now, used to say that whenever hospitals put a target for how much harm or how much errors are acceptable, because they think that it's zero harm, it's unacceptable, or it's not achievable. We always have to ask back. If you see 2,000 patients today in your hospital, you're basically telling me that it is okay to harm or to let errors harm 200 of them. Can you tell me which of those 200 will be harmed, that you will accept it today? So this is what we need to keep in mind, that errors will always be there, and I'm really sorry, my dog. Errors will always be there, but harm can definitely and should definitely be aimed at zero. Because again, for each percentage we accept as hospital administrators, there are faces behind those numbers that will definitely be harmed. I'm just going to shut my dog for a moment.
Thank you very much, Dr. Sophia. Let me just check the chat. Okay, so I have another question for Dr. Anabela Coelho. And when we talk about patient safety and culture related to patient safety, what came to my mind was that culture is something that we incorporate in our behaviors and in our point of views, and you grow within a culture, a specific culture, but you also learn to behave in that specific culture. You learn the ways of that specific culture. And as you are also in an academic context, you are a professor at the Technology School of Lisbon, what would you suggest that it should be improved within the academic context to improve this culture within the student the student community, you know, how they could learn a safety culture earlier during their learning processes.
Thank you, Rafael, for your question. Are you hearing well? Listening well?
Yeah,
okay.
Yeah,
Thank
great,
you.
thank you.
So, in my opinion, students should be involved in this knowledge since the beginning, since the first level, first year of their graduation, because this kind of culture that you want to create at the hospital or at the primary healthcare unit is not something that you could build directly in these institutions. You need to have these values, which you as student, and be proactively in your heads during your internships, during your experiences. Even if you are a student, you should be aware about these actions that you could have as student to promote a better culture, a much better patient safety culture. So it is important that students from nursing or other healthcare professions to be really supported by teachers in this area also. I don't know if you have any curricula, a specific area of your curricula for these matters, for these issues, but if I remember 22 years ago, we didn't have any subject about these kind of things. So, and otherwise, we should realize that when we are talking about patient safety culture, we are talking about also about the organizational characteristics, but also the attitude of the profession, the professional. So this is why schools are so important, in my opinion.
Thank you very much. Thank you very much. So let me check the chat. My next question was going to be to Dr. Teresa, but we have a question to Dr. Teresa, so I will pick that question. And Paulo Santos Costa asks, so I was very interested in the profiles you presented. Will it be right to assume that throughout their career and experiences in clinical setting, the same nurse can assume different roles? Also, was the instrument tested only in clinical practice nurses? If so, was the sample mainly from hospitals? You can try.
Yes.
Okay, yeah.
Thank you. So I think what she's asking about is the different roles that individuals have over their profession, whether or not they're either the victim or a bystander or a potential abuser. Is that where I think the question was going?
Yeah.
Okay, so I think the biggest thing with civility and incivility is, again, if 90 to 100% of individuals experience incivility, bullying, or lateral violence in their career, I definitely agree that we all go through permutations of different roles in our careers, and it depends on where we are, because as again I said, that we can't all be the victims, that we all have to have some sort of insight or perspective or self-reflection and self-awareness of what is the behavior that we might be perceived. And that's why we liked the survey, because it asked the question, have I stepped over the line? Could some of my behaviors or actions or words contributed or be perceived as stepping over the line? So I would say we're all on the spectrum somewhere, and having insight in that is very key. And when we did the survey, we did include all the way up to the director of nursing. So it was bedside nurses, and we went all the way into nursing management. And we tried to give as much anonymity as possible to the survey. So we allowed people not to say what unit they worked on, but we kind of grouped nurses together, either medical, surgical. We tried to group the intensive care nurses together, the OR, the procedural areas, because their work environment is completely different than outpatient setting or medical surgical. And we allowed them to try to really, and it was a validated and reliable tool, published in the US. They had published it in 2017 and again in 2019. They gave us permission to tweak some of the questions slightly for our multinational workforce, some of the words we knew that would not translate well into a diverse workforce, and some Middle East specific issues. So we really feel that one of the things that we do is, we have 21 directors of nursing or CNOs that work with us, and we have them in our civility program. They actually give a version of this lecture to their nurses, and they're doing it monthly at their general nursing orientation. And I can say, they say to me often that whenever they're doing it, they have to, I had a CNO say to me that when I do it, I think about how I treat my secretary, and if I have to reflect on how I'm treating her. And sometimes even for myself, I get caught up, you get caught up in work, and you get caught up in politics and other things. And every time I give the presentation, I have to check my own behavior, because I realize I can't be the person giving this presentation and being a perpetrator. So I think we all take different roles at different times, and perception and self-awareness is key.
Thank you very much, Dr. Teresa. So I have a question. We still have some minutes to Dr. Mawahib. And the question is related to which were the main barriers in the creation of this important guideline that you reached at the end of the research? Was there the stakeholders, to find the right stakeholders? I don't know.
Well, there were many barriers, to be honest, but the main ones were, I think, there were the lack of knowledge of people. You would be surprised that even physicians who we work with very closely underestimate the input of nursing into the patient care. So we had to, in one of the conversation, for example, it was with an ophthalmologist. And he's like, well, a nurse is a nurse. You know, we're talking about, you know, this nurse doesn't have experience, for example, in the ICU. So we cannot just pull her in the ICU from the floor. It's like, but she learned nursing. So I told him, okay, you're ophthalmologist. I said, can you do appendectomy? It's such a small surgery, isn't it? He's like, no, people go for training for that. Well, I said, nursing is the same. So the biggest barriers, I think, they were the administrators, and majority of them were physicians. And they only look at things from physician aspect, and they don't see how valuable a nurse can make a patient's life. So the example that I always give them is, my background is CB ICU nurse. I said, a best surgeon can do the best surgery for a patient, okay? And he will go home, and I can kill a patient in 5 minutes if I don't know what I'm doing. So making the awareness and the understanding of the administration was the biggest barrier.
Thank you very much. So maybe we have time for one last question. And I see a question here in the chat to Dr. Sofia. Joana Souza asks, how can hospital administration prevent hazards within healthcare providers?
So thank you for the question, Rafael. So basically, the first thing to do, and going to what Ms. Mawahib just mentioned, anything you want to do and change from a culture perspective in a hospital, administration is key. Administration can make it or break it, right? And the first thing that needs to happen is for them to recognize that there are hazards for healthcare providers. Okay, and it's not just yes, I know that we have that, and especially now, during the pandemic and after. I mean, luckily, I don't want to say fortunately, but one of the positive sides of the pandemic was really that, the mental health aspect, because hazards for healthcare professionals is not just the physical hazards. We have several types of hazards, and perhaps the one that it's most common spoken now, it's the mental health related ones. So first of all, they do have to recognize they do exist, and they do have to recognize the impact that it has in their hospital administration, not just the impact of the workforce that they manage, but also, one of their big concerns or scope is the financial aspect, and they do have to recognize that there is a big impact financially as well. And going to Teresa's conversation about the, how civility or incivility can also make or break it, and the impact on nursing turnover and the impact of that into the institutional financial profile. Now, once they've recognized it, that they do happen, and once they do know what are the most prevalent ones, and this is important, going to Dr. Annabelle's presentation, running patient safety culture surveys. I'm not sure in Portugal how often they're run in hospitals, and if they are run, how often they're taken seriously. They can give us a big insight on what's going wrong and what kind of hazards healthcare providers go through. And once that is all set up, somehow identified and recognized and prioritized, then they do have to pull the nursing or the healthcare providers into the table and ask them, how are we going to fix this? Because again, especially nurses, we're so used to not sit at the table. I know in Saudi we try to change that paradigm a lot, but we do need, administrators do have to ask those that will be affected by their decisions to sit at a table, to ask them what is that is most important to you and what will be possible solutions. And then and they will be amazed how many solutions we actually could provide them. And then their role would be to facilitate and to provide more or less those solutions to the healthcare providers according to the capacity of the institution. So, I know it sounds quite simplistic, and sometimes we tend to make things more complicated than they actually have to be. But going back to the question, one of the most important things is to recognize that hazards exist. What are the ones that are more important and affecting the healthcare professionals? Ask those professionals to sit at the table and to really draw the solution strategy with them and not just for them, because chances are it's not really going to meet their needs. So this will be my suggestion.
Thank you very much, Dr. Sophia. So before we finish, we have 2 minutes until the end. Before the closing of the main room, I would still want to keep your attention to one last topic. The Phi-Xi chapter started in January 21, a fund to support students to prevent poverty and social exclusion of students, which was particularly augmented during the pandemic. We currently, until now, helped many students to face their urgent needs during their studies. So here, if you want, you can make a donation, you can help us help another student during this year, if you want. So in 10 minutes at 5 p.m., we will have oral communications, the links, so you can access are on the webpage of the event. You also receive them by email. So we will meet at 5 p.m. again together. Thank you very much to all presenters for such an interesting topics, and to all participants as well for your time and for your interest. The Phi-Xi chapter is grateful to everyone. Thank you very much.
Thank you. Thank you, Rafael. Thank you, everybody.
Thank you, Rafael.